Amjad, please can you add Dr. Khammaz as one of the speakers? He's in the attendees list. Thank you.
Your hand so we can promote you to panelists before we start our webinar.
Can you hear me?
Yes, Sarah. Please go ahead.
Okay.
Amjad, good morning.
This is Marie. I don't know, from my computer, it looks like Sarah Benavent, but it's Maria Gat Jean-Baptiste.
Okay. Yes, then you have been promoted to a panelist. Hello, Dr. Khammaz. Good morning.
You hear me?
Yes, I can hear you. Fontaine, I see your hands up as well. Hello, everyone. Good morning. This is Amjad Malab speaking, the co-coordinator of the MENA Learning Hub and the programs coordinator at MENARA. And we would like to welcome you all to our webinar titled Navigating the Future, Transition and Sustainability of HIV, TB, and Malaria Risks. This webinar is the work of the Middle East and North Africa Learning Hub in partnership with the Anglophone Africa Learning Hub, Asia Pacific Learning Hub, Eastern Europe and Central Asia Learning Hub, Francophone Africa Learning Hub, and Latin America and the Caribbean Learning Hub. So thank you, all Learning Hubs, for your work. We'll go through the housekeeping rules for this webinar. So just to let you know, there's interpretation into Arabic, French, Russian, and Spanish. Please join the language that you feel most comfortable with through the option within Zoom. Also, just to let you know that this webinar will be recorded, And the recording will be available in all languages after the webinar. You will be able to get them throughout the links will be sent out and or throughout your learning hubs. The duration of this webinar should be taking around 90 to 100 minutes. And if you can please stay on mute until we reach the Q&A section. And during this session, please raise your hand so we can give you the permission to unmute yourself and ask your questions. Anytime during the webinar, you can feel free to add your questions within the chat box. So now we can officially start our webinar. I'll just go through the main objectives of this webinar. This webinar focuses on showcasing opportunities and strategies in domestic resource mobilization and innovative financing mechanisms. It will also highlight the role of the Global Fund in ensuring a robust transition and sustainable plan. It will help us present strategies, tools, and best practices to improve the preparedness of CSOs and CBOs on institutional strengthening and diversification of their funding sources. We'll have the opportunity to share experiences from different countries across the globe that have already begun or completed their transition. It's an opportunity to strengthen the skills of everyone attending, from CCM members to civil society actors and the community in risk management, global fund transition planning, and domestic resource mobilization. Also, this would be an opportunity to foster regional and global dialogue, allowing actors from different countries to share lessons learned, protective strategies, and advocacy efforts. This is like a quick objectives of this webinar. We'll be launching our webinar with an opening remarks on transition and sustainability. Are we moving strategically enough? We're more than happy to welcome Mr. Emmanuel Olatunji, Fund Portfolio Manager in the MENA team at the Global Fund. Mr. Emmanuel, the floor is yours.
Thank you, colleagues. Good morning, and good morning, my brother and the moderator. And thank you all for your collaboration and for inviting us to be part of this initiative. And thanks to the MENA Learning Hub team, has been coordinated by the team. And Amjad, I also want to thank you for the collaboration that we've had and the different Learning Hub seminar series that we have shared together. These consultation for the Global Fund and for MENA and for the region, it's so timely, and I really want to, on behalf of Lynn Sosi, the regional manager for Middle East and North Africa region, convey a congratulatory messages to affirm the direction of these thinking and strategies and forward planning in terms of sustainability and transition within MENA region. It's not a new information to say that in MENA region, we are already seeing a increasing in the incidence and number of diseases across the region, particularly for HIV and for TB. Within that space also, we also know and fully aware that we are seeing a dwindling of financial resources and even donor organizations within MENA region. And that in itself is not also matching with the rising number of cases compared to the global reduction that we see as projected by UNAIDS. And so with that in mind, it beckons and raises the question to say, how do we continue to work in MENA region where we are seeing reduction in funding, but also a growing need for response, and with the different actors that need to be catalyzed and supported and also mobilized. Of course, one of the critical actors here is this community engagement and the role that the civil society organizations, CSOs, will continue to play, in addition to the role that community health workers will also play in ensuring that we have a sustainable, continuous, and effective and efficient access to treatment by those who will need treatment, we ensure that we're sustainably able to also offer care and support for TB, for HIV and malaria as well. Now, to move us towards that sustainability, we have seen in GC6 Grand Cycle 6 and 7 of the Global Fund, as part of the guidelines of the Global Fund in ensuring that countries are moving and thinking around sustainability, we have seen funding earmarked for community sustainability agenda, community dialogue and consultation in different national grants. And we have also seen the same in the regional grants. And as such, I think Breshna, my colleague, will be speaking on the technicalities. But when you X-ray across all the MENA region, MENA countries and portfolios of the Global Fund, you will continue to see that there are pockets of initiatives that are emerging, tailoring towards sustaining health investments. However, a critical gap will mean that how do we do this in a way that is different, in a way that is country-owned, in a way that is country-led? And that will mean that we need to have a critical mass that will lead towards an effective advocacy, an advocacy that looks at the national needs, an advocacy that looks at how do we engage with key stakeholders or those in authorities. And I think this is where we need to begin to think around the future of sustainability. Now, sustainability for us will also mean that for us, when I mean all of us, will be a game changer for us in MENA region if we do it A, right, and B, timely, and C, consultatively with all stakeholders. Doing it timely, which is what we are having the discussion now, is to say, and which I congratulate all of us to say, how do we begin to bring our minds together and think towards and having a roadmap that will lead towards a sustainable agenda and a sustainable engagement? Number two, who should we be engaging with? I think given the fact that we have already started some initiatives across MENA countries, like we have initiatives like cash transfers, we have initiatives like social contracting, we have initiatives like advocacy. How do we leverage on those, particularly from other countries? And I hear, Amjad, when you flag the objective of this meeting is to learn and to share experiences. How do we learn from those pockets of initiatives and cascade them or scale them in a way that we are able to bring government and other stakeholders' attention? Of course, driven by civil society organizations. Lastly, is the question of capacity. And I think here is where we feel it's important for CSOs to be capacitated and to even have the capacity and to even employ the capacity, or yes, employ the capacity and use those mediums to be able to create a structure and a process that will lead towards the development of a roadmap. How can we as CSO organization regionally have a kind of a regional roadmap that will help us engage with our national entities and blocks, including regional organizations, to be able to address the issues of sustainability for health, and particularly for TB, HIV, and AIDS, TB, HIV, and malaria. Number three, takeaway message that I want to leave us with is number four, is to see what are the type of partnerships that we need to draw in here. And the partnership can vary across stakeholders, across region. We are already seeing that there is a progressive reduction of the number of financing institutions and mechanisms in the region. What does that mean? Do we need to find new frontiers of partnership? The role of private sector in supporting and working with all of us around sustainability. What are the roles of community gatekeepers when it comes to advocacy for sustainability of health programming and investment? And then we move towards the ministries of finance. Oftentimes, we work with the Ministry of Health mostly, but then there are other critical stakeholders like the Ministry of Finance, the Ministry of Justice, and all Ministry of Budget that we can engage and work with differently and then pull together and find a way of working. So in conclusion, we through MENA region, we have some investments that we are putting through what we call the catalytic investment through the MC MENA Multi-Country Response Grant that focuses mainly on two principal objectives. One is to how do we support and finance and ensure that there's a sustainable financing for TB and HIV programs in the region. Number two, how do we put in place advocacy mechanisms that will support sustainability agenda in MENA region? I think these two opportunities will give rise to some new initiatives and learning opportunities that we can continue to carry forward, even as we plan for GC8, using the resources that we have from GC7. And I really want to say a big thank you to the organizers of these events. I see that we need to keep to time. The organizers of these events, and also my colleague Breshna will be sort of teasing out some specifics and some technical elements of this event. On that note, on behalf of our MENA team and MENA region from the Global Fund side, we really want to wish you all the best with this discussion, and we look forward to the outcome of this deliberation, some of which we can inculcate within the implementations of the grant. And all the best. Thank you. Back to you, Amjad.
Thank you very much, Mr. Emmanuel, for your introduction for this webinar. And thank you for setting or paving the way for Breshna. So Breshna is the Senior Health Finance Specialist at the Health Finance Department at the Global Fund. Breshna, the floor is yours to introducing the Global Fund approach to sustainability, transition, and co-financing. Please go ahead.
Thank you very much, and thank you very much for this opportunity. It is really timely because we are working on many portfolios in the Global Fund, given the changes in the environment that we have all experienced. I think many of us always wish that the Global Fund or all the other like PEPFAR, the agencies will stay until the job is done, until the diseases are eliminated. But we can really see that realistically that might not be possible to do that. So there is a lot more help needed here, especially from the domestic side, for us to join forces together and make sure that what we have invested in is sustained. So I have some slides. I'm going to share my screen. Please tell me if you can see it.
Yes, we can see the screen.
Okay, perfect.
If you can go to the presentation mode.
Yeah. Is this better now?
Better.
Okay. So I will go through this presentation covering three areas broadly. The first is what the biggest challenge that we have seen while working on the community work is that they are usually outside UHC and PHC planning, which is quite a problematic thing when we start talking about domestic financing. And then we can talk about what are the paths, what we could do to achieve that financial sustainability through domestic financing. I will bring in a country example that I'm working in very closely to bring community work closer to the public financing, and then some opportunities in GC8 that might be helpful to leverage from the Global Fund side. So the first part, the communities do deliver essential services. Most of our funding in terms of Global Fund funding goes to the outreach of key population, peer-led testing, counseling, case management, right-based advocacy, and others. And these are quite integral to the health sector, while they still remain quite invisible in terms of public financing. And when we are trying to discuss them, they usually are not part of the budgets. They are not part of the insurance scheme and benefit packages, which makes it much harder for them to transition and to transition abruptly if there is ever a funding issue. So I'm just laying out a few risks that if we are not planning properly for the sustainability, these are areas that are usually very heavy donor reliant. There is not an automatic shift to the domestic financing. It's a long road. I can later show you examples of what it takes to shift even one service to the domestic financing. And the risk of disruption is quite huge especially when they are massively donor reliant. So the path to sustainability, when we are looking at what are the key population getting these services and who is paying for those services. So there is the primary healthcare doctors, nurses, then there are community health workers that are hired by the centers or the authorities that are part of the facility. And then there are the non-state actors or CSO that are providing community services. And this is the part that is usually coming from other sources, public and private, and not from the health budget or health insurance. So shifting that to the health budget or integrating them within these other two buckets is a task that we are trying to achieve in the transition planning. And this is not an easy one because a lot of times when the skills are not aligned or the services that are there are not part of the plans and the benefit packages. So shifting that to domestic financing or the cost we are working on, like there are different costs we are paying than what the government would be paying. So there are several challenges that come when we are talking about the community services and how they can transition. Now, I'm just going to show an illustrative example, which I'm working on a few countries where what are the opportunities where we are looking for integration. So they could be integrated into public health system. So some of the, especially TB services, there is an equivalence in the domestic financing. So if we have community services delivered by public facilities, we are looking at how to integrate. Because if we imagine a scenario where Global Fund or other donor support is not there, then where does that support go? And if it's an essential service that needs to be delivered, that goes into the public health system, or there is a local government, a community-driven funding that is very subnational. So sometimes those entities will be taking over some of the services that are more population-based, advocacy, outreach, all of that is sometimes very in local budgets, in subnational budgets. And sometimes we are dealing with countries where we have hired one PR to serve 500 geographies, and it's very easy for us to hire community health workers in thousands and have them deliver those services. But the moment we are talking about the transition of those services, they will go to those local government, and that means we are talking to 500 different budget holders. So it's quite a daunting task. And the third part, which is quite an important one, is the social contracting. Now, these are usually for services that have no domestic equivalence. There is no domestic pathway. They are not covered under any insurance. They are not covered under any public health facilities. And what we face is a situation where we need to have some arrangement in place with the government to contract them. And this is usually in the HIV space, from my experience so far, that we have some outreach services, some services to the key population that needs to be contracted. And we have some very good examples that we can speak to later, I think, in this webinar. One of the most important aspect which I'm facing challenges with is that sustainability preparation is not equal to reduced allocation, because I have worked in several countries where it's perceived that if I'm preparing for transition, if I'm working on the domestic financing, then global fund funding will be reduced. That's actually not the case, and it needs to be clarified that allocation are formula-based, that are based on disease burden and country income level. So whether you prepare for a transition and plan this does not affect the allocation amounts. What we are trying to do in the transition planning is to identify what functions are we supporting. Is it Ministry of Health? Is it insurance? Is it subnational budget? And who can take over? And then look at the enabling actions that are needed so the grant can be designed from that lens to support those actions to eventually help in the transition of these services. So it is important takeaway message here is that we need to be ready for the future, and we need to make sure that when we have the money from the Global Fund, when we have the opportunity, we make the best use of it right now. This is an example of just showing you what a social contracting would mean. So it's a very illustrative example, general example. Every country is very different. You could be in stage 1 and 3 at the same time. So I've tried to capture it in stages to show what exactly is needed. So we need to do an assessment of the baseline. What are the services that are being procured through communities? So all of that needs to be assessed. And then the development of social contracting, a legal framework, the capacity building, because a lot of times we are told that the social contracting needs are that you need to have a certain office space, you need to have certain financial management capabilities, you need to have upskill the community workers. So all of these things need to be aligned for us to start having that conversation with the government for contracting the CSOs. And sometimes those legal frameworks are not there at all. So they need to be developed. And what we do usually is looking at other sectors. Usually education sector has a lot of good example of social contracting. So what we try to do is to have that cross-sector collaboration to build something on the social contracting, taking lessons from another sector. So each step is a very long process in itself. And by the time you actually reach a moment where the social contracting is done and there is a budget line and funding is allocated to it, it can be quite a long journey. So we need to start as soon as possible. And in some countries, we are looking that they are maybe far ahead, like in stage 4, while some countries are in stage 0. And unfortunately, majority are in stage 0 that I'm actually working on. I want to bring an example of one country that I'm working very closely with. It's Indonesia, where social contracting has been discussed for the last 15 years. So the last engagement we had in Global Fund was 15 years ago, and things are moving very slowly. So we have some example of social contracting. Now, the main challenge we identified in Indonesia is that there is not a business case. It's not that the contracting environment is not there. It's not that the legal frameworks are not there. It's more the business case. Why should we contract you? So that was the main thing that came out. So I'm trying to contextualize that work and bringing it to the domestic. So to answer that question, why contract you? Because there is a lot of push for social contracting, but the main obstacle is there is no investment case for it. So I looked at the Indonesia health sector plan, the whole priorities, starting from the vision 2025 to 2045, how that vision translates into the medium-term development plan, and health is one of the area. And then how the medium-term development plan translates down to a health for all master plan, as they call it, and how that master plan translates down into an operational plan. So I try to map this all down to embed the community work right into the highest level of policy and planning that the country has in place, so we can start developing an investment case. Now, if I look at the health master plan, which trickles down all the way from the main vision of the country for all sectors, then I can look at the program areas and what these focus on. You can see disease control and healthy living is one of the main areas that there is a focus on. So then I break it down further into the operational plan that is done for the health sector plan. They have 3 types of indicator. The strategic outcome indicator is at MOH level, the program indicator is at the program level, and the activity indicator is all the way to subnational level. So someone is always responsible for their indicators to achieve. We are talking to all these 3 levels. We are talking to MOH, we are talking to program heads, and we are talking to the subnational entities. So I'm trying to see what are the indicators and at which level that we can bring in to show what the community is doing. So if you look at the indicators, so what I did is I took all the indicators that are relevant to the work we are doing and to show how community is contributing to these indicators. Now, another thing that I have to highlight here also is that the community needs to also be very engaged when these indicators are set, because that will eventually translate into the sustainability of the community. Because what I found out when I was looking into these indicators, that there are some key indicators that are missing. So there could be an indicator on the prevention of hepatitis B or hepatitis B or on dengue, and there is none on HIV, for example. So it is something that we need to be mindful of, that when these plans are built, that we make sure that those indicators make their way, because in the end, the budget is allocated based on what they are trying to achieve here. So I laid out what are going to be the risks. So if disruption to TB treatment and diagnostic, which indicator does it link to, and what is going to be the impact? Because what the government and domestic care about is what are they going to, where are they going to fail, and who is contributing what, and how do we allocate funding into that? So I try to map those, and then bringing it all together. These are the functions that communities provide: community education, screening, contact tracing, data reporting, education campaigns, and which indicators are linked to those. It also shows a little bit to us as community that maybe we should not be narrowly focused on one thing. If we could expand our approach, we could do a lot more, because if community education is HIV, hepatitis B, dengue, and rabies all together, how can we expand our scope also to maybe offer more than what we are doing? Because in the end, the budget is allocated to the achievement of these indicators. So just to summarize this, that to secure funding, any officials on those three levels, the national, the provincial, the subnational, they would like to say, I want to do activity ABC. This is what these indicators are tied to, these activities, and I want this amount of funding to deliver. So we make a case for contracting or for integrating the community work. This could be performance linked or to ensure that, the budget prioritization for the underfunded services, such as the supporting key population, needs to be linked to directly supporting those indicators. And that is there, although some work may be needed in having more indicators there. And I would also say that advocacy must align with budget, finance, and planning processes, because when we advocate without all this evidence that I was just showing you, it is hard to advocate. They will not listen. That's my experience. If you bring it into their context, if you speak the language of that domestic financing, they are very keen to support it. And they also, you give them something to advocate themselves for. So some opportunities in GC8 that we could think about, given the experiences that we are gathering, and we are gathering more and more experiences from different contexts of countries with, it could be very diverse. Some countries have criminalized activities that we are supporting. Some countries are UMIs and transitioning. Some countries are low-income countries, and where there is absolutely no funding for or budget lines for those kind of activities. So there are different contexts, and some countries are religiously or culturally very different, where it is very hard to bring in those conversations. That's why I was showing you that if it's hepatitis, if it's rabies, you kind of like bring in HIV into it in those contexts, so we can continue to support. Some opportunities in GC8 for the Global Fund, I would say that we need to start thinking beyond the Global Fund resources, because as I said, the allocation is not going to be reliant on how ready you are to transition. But the more you prepare, the better you're going to be ready when transition is happening. And then engage very strategically to strengthen the channels. I mean, as I spoke, whether it's on the programmatic side to ensure that indicators are included, or taking the existing information and developing that investment case and bringing that to light in front of the officials is quite helpful. So in less resource environments, I would say the opportunity is to rationalize, connect, and influence, and we are happy to support here. I also want to highlight the Global Fund Sustainability Transition and Co-Financing Policy. We have levers like co-financing that we could leverage for the community part, because until we have the money, until we have the leverage, we should use our policy levers to make sure that some of these things are transitioned. Can give you example of countries where I'm saying, okay, you don't have a policy framework for transition. I would like this to be added to the co-financing commitment from the country in the next grant for this to be delivered, which they will be bound to do. In Pakistan, I got a commitment from the country to do the transition readiness assessment and sustainability assessment and planning to make sure that I shed light on those community services that we are financing, which are totally invisible. And as I said, WHO and partners, when they are doing all these PHC and UHC planning, somehow they are only looking at doctors and nurses and public facilities and insurance schemes. They are not looking at those communities and that the donors are financing. I had many of those conversations with World Bank and others who are working on, for example, HRH planning in a country, and they do not include the community because they say there is no data. This is not something that was communicated to us by the government. And as we move on the continuum of the income and disease burden, transition planning and sustainability planning becomes essential. So we can leverage the STC policy to make sure that we have that planning ready. And then just one last slide is that we have included, given our experiences, we have included some interventions in the Global Fund modular framework, which makes the basis of any funding request. Especially on this, you can see that there is community-led monitoring and advocacy on the community system strengthening. Then there's under health financing, there are very specific ones for social contracting, for example, and health financing strategies and planning where you can have the sustainability and transition planning and co-financing commitments if the co-financing commitments needs to be strengthened. So, or data and analytics or blended finance, as some initially we were saying that there could be innovative things as well. So you could make use of those this RSSS module and these intervention to include them in the next GC8 grant to make sure that that readiness is done. So that's all from my side. Thank you very much. Over to you.
Thank you, Brashna, for your introduction and for the important information that you have given us. Now we'll move into more on-point experiences. We'll share the country level experience on the development of social contracting legal framework. We're happy to have Dr. Nishant from the Human and Social Development Sector Office at the Asian Development Bank. Dr. Nishant will share India's experience about the transition context of the country, what was the policy and legal environment, and what changes were expected, and what were the key outcomes. Dr. Nishant, please feel free.
Thank you. Thank you very much, and I hope you can hear me properly. So thanks a lot first for inviting me for this webinar, and I think this is a very timely and very important topic. I think everywhere we are talking about sustainability. In the current global context, this becomes more and more important. So, I was very happy to see the presentation of Brashna because she talked very nicely about. She elucidated what Global Fund is trying to do, and from community and up, how it is being done. So I thought that we can actually take a role where we can share from our side, from top down, in the sense that the policy level, what is being done, at the country level, what is being done, and how it impacts what's happening at the field level. So for Indian example, I wanted to share. So what happened that, like in many other countries, India also faced a huge fragmentation. So some, I think, because of the history of the country, and some because of we donors like to have fragmentation in the country. We want to push various vertical programs. So there are so many vertical programs which are going on in the country. For every disease, there is a vertical program. Government tried to bring things together a little bit, but still, I think a long way to go. At the same time, we also saw that only the supply side system which government had, where government set up and operate public healthcare system right from the level of the villages to the national level, provide all kind of care, something which was still lacking. So it was doing good job, but there was a huge workload for the people. And at the same time, the population is large, and also there were gaps in the service provision. So government decided that they would like to also introduce health insurance. So when I say health insurance, it's not private health insurance, which already exists in the country. This was more about social health insurance kind of thing, or national health insurance, I can say, where government said that for bottom 50% of the population, we will pay the full premium, but we will, and people can go and get free services in public and private hospitals. So now, the situation is, because of the health insurance which started in India, I think this new one around 7 years back, 2018, we started it. There is a situation where the same diseases are covered under vertical programs and supposedly provided free of cost in the government facilities. But at the same time, they are also covered through the health insurance program, where again, they are free in both public and private hospitals. So which means that for the same thing, government sometime may pay twice, or also it may happen that it falls between the cracks somewhere, the payment. So the challenge what we saw here, that because of this duplication which is happening in terms of the provision of services, we realize that we need to bring things together so that we can try to remove this kind of duplication, which will help in sustainability more, because the government will otherwise spending twice, one through health insurance premium, another through the payment to the public healthcare system. So in some states in India, because India is a huge country, now we are experimenting, or we are implementing a system where these vertical programs have been integrated with the National Health Insurance Program. So the idea is that the fund which was channeling through the public healthcare system only, now they are being channeled through the health insurance program, so that only health insurance program will pay for a particular disease, for example, like we have a National Blindness Control Program or TB control program. So in some states, the idea is that you bring all this together, and then all that can be paid through the health insurance program. And that will help in a way that, number one, of course, you save on the cost because you remove duplication and unnecessary cost. But on the other hand, you have much better handle of data, because now you can track how many people have come, what treatment they got, because the data of health insurance, the IT system, is much more robust than the overall data which we had for various programs from various states of the country. So, and earlier it was in two places, and there was no national ID which for the health programs, which was linking all of them together. Now with this, it's much easier to do that, because we are getting a national ID for health related activities, and at the same time, people will flow through the same system, through the same software. So you can see actually who is going where, what kind of treatment they are getting, and the payment is only being done from one place. At the same time, you can then also leverage this for economies of scale to get better prices, to negotiate better prices with the providers. So that all also has been done, which will help us to actually get much better idea and much better handle on the ground. Now, the challenge here is that if you do that over, basically health insurance program in the field, then also we have to see that how do we engage that communities are able to get the services. Because often, many times, what has been seen that when countries are launching these health insurance program, especially the bottom vulnerable population, even if they are target population, many times they are maybe not aware, they are not very literate, maybe they don't know how to get the services, access to services. So how do we bring that up? So that's where I think engagement with civil society organizations and all have been tried in many places, which have been proved to be very useful, where the idea is that they help the people to get access to services. They help the people to make them aware about what are their rights under health insurance, how they can get actually benefits about the services, and if there is any problem, where they can go for their grievances. So from community participation, bringing community groups together to actually again make each of them aware about the services under the health insurance program, we have seen that it has worked quite well. We saw that it has its own challenges from the other side, but we have seen that overall it has worked well, where people have been able to get access to services, people have been able to get better information about the services which they were not aware earlier. So it becomes a win-win game, because on the one hand, people get better access, on the other hand, government is able to save money, but still it is being done more on an experimental basis in many states or provinces. It's not a national policy as of now to do this way. And that's where I think our efforts are. And I think in partnership with Global Fund and from our side, from ADB and other multilateral, bilateral agencies, we are trying to bring this kind of idea with the government, that how do we try to remove this fragmentation, or if not remove, at least reduce the fragmentation, and then try to bring things together. So that is what something we are hoping to do. And that is where we have seen some early examples where it has done quite well. The challenge would be also that to find ways in which international organizations like Global Fund and ADB can provide their funds, so that it can also match the requirements of the development agency, but at the same time, it helps the country also to reduce the fragmentation. So this is what we are trying to do. And I thought that in a brief presentation, I can share this. I'll stop here. Thank you.
Thank you. Thank you very much, Dr. Nishan. To continue within this context, we happily have with us Fayrouz to present the community representative of the country level experience in India. He will be sharing with us community mobilizing challenges and bottlenecks and lessons learned. Fayrouz is a human rights advocate with a strong focus on access to treatment. He has been actively involved in advancing issues such as access to ART, essential diagnostics like CD4 and viral load testing. He has trained people living with HIV networks and individuals on legal and human rights, empowering them to utilize redressal systems. His work also includes building robust community networks and developing care and support centers, which have been integrated into the National AIDS Program. He's also a member of the community delegation of the Global Fund to the Global Fund Board. Fayrouz, please, the floor is yours.
Thank you, Amjad, and thank you, MENA Learning Hub, for giving me the opportunity. And my previous speaker, Dr. Jain, has also talked about the universal health coverage. So I'll take it forward from here. So as we are moving forward, and some of my previous colleague has also talked about, we are at very crucial juncture where a lot of funding it's reducing in many fronts. And as a result, we are seeing with the less resources, we need to do more. On the contrary, India, I'm talking about the India experience. In India, what we have also seen, the infection of HIV has increasing post-COVID. So we are seeing a spike in the HIV incidence, and India is also contributing like more than 1/4 of the world TB burden and substantial high cases for the malaria. So these are the country scenario currently. However, with regards to the social contracting, if I talked about on this aspect, so India is one of the country where Varsha was talked about various stages. So India has come a long way. We have a format of the social contracting where the community-based organization and civil society organization have been contacting to implement the program, and that has been for quite long time. We have a example of targeted intervention program for HIV prevention. More than 1,000 sites are being implemented for various key population, be it at the sex worker, transgender, MSM, and other key population and vulnerable population. We also have an example where the apart from the Ministry of Health and Family Welfare, the other ministry, such as the Ministry of Social Justice and Empower, is also supporting a few activity. For example, shelter home for the transgender individuals and harm reduction program for the PWID. So based on this, so India is working quite well on these aspects. And recently, those control program, and now with a gradually organization is taking the current support program as one of the strategic intervention to support people living with HIV. With regards to the community mobilization, in India, we have a very strong community representation started from various key community committees, for example, national working group, state working group, even at the district working group. So we have a quite good community population who are actively contributing in various programs. Community mobilization, I think it's done quite in a good manner with the support of again with the global fund. We did it one of the community-based program called Pehchan. This program was created or strengthened more than 200 community-based CBO for transgender and MSM group. And currently, we are working with a care and support program in which the program has supported more than 300 CBO, where they are supporting them in terms of building the community system and implementing the community program. So these are the few things. With regards to the legal challenges and with regards to the legal framework and the policies, in India, we have a various legislator which is also supporting for the social contracting and have a welfare policy. For example, we have a HIV Control and Prevention Act, which is passed by the Indian Parliament in 2017. So, which is also talked about for the social welfare and welfare of the community in large. We have a Immoral Trafficking Prevention Act, which talked about the welfare of the sex worker. Transgender Person Protection Act 2019, which talked about the welfare of the transgender, and National AIDS Control Program Phase 5, which is currently running, which talked about the bringing community larger into the program. However, what we have seen in the universal health coverage, because India has taken the eligibility criteria of 2021. So this is 15 years, 14 years back. A lot of people who are eligible for this program are not actually getting services because they are not part of the eligibility criteria. We have also seen delayed in policy implementation and as a challenge in the legal framework, which is limiting the capacity, limiting the role of the community networks very less, and limited financial autonomy for the community-based organization. They have a limited autonomy. Capacity, because a lot of these people have, like my previous speaker talked about the capacity issue. We have seen the community-based organization or the people who are affected with the community has a limited capacity. So the capacity in terms of management, reporting, and compliances, that is a challenges we are facing. And persistent stigma, because we have seen the stigma and as a extreme form, the discrimination limiting their access and their participation in overall program, and dependency for the donor-driven program, which is ultimately drive everything apart from the community thing. What lesson we have learned in terms of how we can go? We need to build more community system which ultimately help the program. What we have seen currently and now, since everybody's talked about the sustainability and integration, we also need to see the fund and apart from the national funding, because in India responsibility do not know how to tap these resources. So if we have a program which is ultimately building the capacity of the community network on the social or resource mobilization, which will be ultimately help for the sustainability. We have also seen, and the legal framework should also be supported with financial security. We have seen the continuously capacity building required for the community institution, not just for the a program implementation, but also as a like meaningful contributor in the countries achieving last like SDG target. Partnership with various government, civil society organization, and with other stakeholders. So that is very much required, and this need to be further strengthened. And social contracting, which currently going on, need to be further strengthened, which and increase their ownership. That is required. So based on the country experience, we can say the social contracting currently which ultimately help to achieve. Amjad, over to you.
Thank you. Thank you very much. Now we'll move into the next section, which is the Q&A section. Please, in case you have any question regarding any of the presentations that we have already provided from Emmanuel, from Breshna, or Dr. Nishant and Firouz, please feel free to raise your hand and we'll give you the opportunity to unmute yourself and ask your question. Or if you would like to ask your questions throughout the chat, please feel free to do that. So we'll wait for attendees to just raise your hand and ask your questions. Okay, we have Armand and then Nanette and then Helen. Please, Armand, if you want to start.
Yeah, good morning.
Good morning.
Je voulais vous demander si on pouvait avoir, comment dirais-je, a sustainability tool. Is it possible to get a sustainability tool?
The sustainability tools of the Global Fund.
Yes, he would like to know if they can have a sustainability tool.
Un outil de durabilité. Est-il possible d'avoir un outil de durabilité?
Is it possible to have a sustainability tool?
Okay, so this is the first question. Nanette, do you have a question?
Thank you very much for all the presentations. I would like to know a little bit more about the social contracting of how this has been working. Has it been social contracting with community-based organizations, with private sector or other kind of institutions? Just to hear a little bit more concrete about the social contracting. Thank you.
Nanette, the voice was so low. I don't know if any of the panelists could have heard you. Could you please repeat the question on a higher voice, please, or you can write it in the chat?
I heard it. I can respond to that.
Okay, perfect. Please go ahead, Rashna, and then we'll move to Helen.
So I can respond to the two questions, and others please do complement. On the sustainability tools, so we don't have like a tool developed that we can use to assess. I mean, not that I'm working, because the contexts are so different, but basically like the framework overview that I can give you is what we are trying to apply here at the Global Fund is the what, who, how, and when. What is basically what are we financing? So really defining that, but not defining it in terms of inputs, but also functions and their importance and how they are linked to all the national priorities. Then we say the who is going to be the purchaser that is going to take over. Is it a subnational entity like community health workers that are there, or is it a national Ministry of Health, or is it the insurance scheme? Because in many places, the insurance is the one delivering the packages and they are the one contracting the communities also. So defining that. And then the how and the when, which is quite an important, is what are the barriers? There are technical barriers, political barriers, or financial barriers. And what the severity of those barriers are. They're like really long-term issues that needs more time, or there are things that we can fix, like maybe capacity issue that we could be fixing in short to medium term. So short, medium, long term. And the when defines like by when this would be feasible. And of course, there is risk and mitigation and monitoring to make sure that we course correct as things change. So that's the overall, the framework we use. But I think that the most important would be to whatever opportunity we have in terms of grant financing or support or TA from other partners, to use it now to have that analysis, because every country is very different. I have very big countries where we have massive commodities to transition and less community. And then there are countries in Asia, in MENA, there is a lot of focus on the community and the importance of those communities to deliver those services. So that's more on the, like what we could also establish is some tools also to simplify this if that is what the need is. And I think the organizers are going to look into this a bit later on in the webinar. On the social contracting question, so contracting, what we are trying to do is to be domestically contracted. This domestic contracting could be from the ministry, from the subnational, or from the insurance schemes. We have examples of all of them. It is not community or private sector that we are working on in terms of contracting. It's more the domestic and the government that we are working on. For example, we are delivering PrEP services, for example. PrEP services and the commodities maybe come from the central government, and the services are delivered through the insurance scheme. So we are talking to the insurance scheme to contract those services directly, because the insurance scheme will provide the funding for those services to be delivered. So if you receive 100 patients, you're going to get the funding as part of that package from the insurance scheme for those patients. So it's basically, sometimes people do call it social contracting. Other times people prefer calling it just procurement of services of the community, or different names can be used. But basically the idea is to have the government contract the services directly rather than it reliant on the donor financing. Thanks.
Thank you, Rashna, for answering the first two questions and answering Helen's question as well in the chat. We have another question in the chat from Becca. How does the Global Fund view backsliding on the rights of vulnerable groups worldwide in countries where anti-LGBT laws have been adopted or where communities are criminalized? In such countries, to what extent will it even be possible to discuss something like social contracting? This is one question. Also, we have a question in the Q&A from Duka. Is hepatitis B now part of the Global Fund's intervention programs in Nigeria? What we know is that at the moment, AIDS, tuberculosis, and malaria only. So, God Power also has a question in the chat. Given the fact that social contracting is more of a longer-term measure, what are the immediate and short-term measures available to CSOs to access funding for life-saving services provided by community-based organizations? So 3 questions.
Amjad, I want to take one of the
Yes,
questions
please.
for example. I think the question on LGBTQ laws and criminalization and where we have punitive measures and the difficulties and challenge to engage with stakeholders on social contracting subject. We have seen some progress in MENA region where this is also a prevailing situation. We have seen some progress in some of the countries where, for example, Morocco is already making progress on social contracting. We have seen progress in Lebanon also doing similar social contracting where the civil society organizations in both countries are proactively engaging government and government is recognizing the space. But also it's the innovation around how those engagements are done and how we strategize the advocacy. And I go back to the slide on Breshna to say whether we present the investment case in terms of how the priority for LGBT communities is linked to the national health outcomes. So I think there are countries and examples of countries that we can borrow from. Similarly, I know in the work that Breshna does in Asia, there are examples where LGBT agenda has been integrated into the social contracting. And I think there are opportunities for cross-learning and sharing that we can do. I think this question is coming from Becca. The second one also I wanted to highlight is the issue around integration. When we work, I think it was the doctor from African Development Bank that highlighted the fact that we need to move away from verticalization and move towards integration. What are the opportunities that we can find in countries, even where the laws are stringent? We can sort of create opportunities to integrate services or integrate package of services into an existing service delivery models. And that way, we are able to create the a kind of access issue, but also move towards the policy issues where insurance companies are able to see that, are able to incorporate services for key populations into their own insurance and all the insurance packages, so that it's not just defined for the general population, but also for specialized population like LGBTQ population, so that they are not being discriminated. And again, beyond criminalization is also the discrimination that is being faced at service or point of service delivery. I think this is where we need to have a different type of strategies that and integration of services for insurancing mechanism where we want to roll out those. So Lebanon, Morocco have promising programs that can be shared as cross-learning. I want to pause there. Back to you, Amjad.
Thank you very much. For the sake of time, we'll be moving on, and then we'll have another session for open discussion and Q&As. Now we'll move to Dr. Marie Agath. Unless you're unmuted. So Dr. Marie Agath, commonly known as Agathi, is originally from Haiti and joined the Global Fund in 2013. She has held various roles, including public health and M&E specialist and fund portfolio manager, working across the Middle East and North Africa, as well as Latin America and the Caribbean. Agath has contributed to several strategic initiatives within the organization. Before joining the Global Fund, she led public health programs in Central America as a medical practitioner and counselor for the Global Fund for Women. She holds a doctorate in medicine and a master's in public health with extensive experience in community health project management and work with NGOs and UN. Since January 2025, Agatha has been managing the portfolios of Morocco, Djibouti, and the multi-country North Africa grant of Algeria and Tunisia as fund portfolio manager. She will join us now to talk to us more about piloting social contracting from the perspective of the Global Fund grant implementation. So please, Dr. Marie, the floor is yours.
Good morning. Good morning, all, and thank you all for joining. I want to thank all the presenters because most of what is happening in our grants implementation at the Global Fund, I think Breshna, Emmanuel, and other colleagues, they already set the scene to discuss about social contracting. I will be intervening to bring the grant implementation context. So, and I think Breshna, well, sorry, I think my slide. Okay, let me try. Can you see my slide? Can you see the slide?
Still not.
Okay.
We can see them now, and if you can go to the presentation mode as well. Thank you.
Good now? Okay.
Yes.
Okay. At the Global Fund, I think Breshna talk about sustainability and transition and co-financing framework that started in 2016, but this has been updated in 2024. But this policy has guided countries towards sustainable health financing. And at the Global Fund as well, have this eligibility policy that listed the countries that are set to transition. I think Breshna also talk about the formula-based context where these countries are identified. Once identified, they would be allowed to have a final allocation to support the transition process, and this has been the case for the countries in the North African region. And even when they are not set, not all of them are set to transition, but all of them went ahead and after the policy formulation, work on the transition readiness assessment. And now the Global Fund is advising that all programs, they embed sustainability in their grant design and planning, and not to wait for the time that they make it to the transition list. And on the transition plan, and this is supported as well by Global Fund grant, we can request all the activities that will support, social contracting, and we will see, as mentioned earlier, that we need to explain why to the decision makers, why should we contract community-based organizations that are delivering services to key and vulnerable population. So, and we plan as well for the design and development of national financing strategies, as Breshna has also mentioned. Under our modular framework, we can find all these activities in social contracting. And public financing of civil society. We also, within the grant, encourage the countries to include them in the funding request. This is the slide where I will spend more time on the lesson learned in the past years, and as mentioned, to arrive to these steps, and I think Grishna again has a slide that describes very well all the steps to reach the social contracting phase. So we have to reach some key milestone, because to explain why and make the investment case, we have to define the minimum package of services that are delivered at the community level. In most cases, it's HIV prevention services to key population, and work towards creating budget line to finance the community-based services, and also all the CSOs institutional strengthening and competency building to mobilize resources and advocate for public financing. And at the same time, all the studies like HIV allocative efficiency study sometimes need to work on an investment case, or studies like social return of investment. And what we have seen in the past, like in the past years, in the past 10 years, the current cost of the services funded by the Global Fund often will exceed what the government is willing or able to finance, because the grant sometimes pay for all operational costs, and also the commodities and all the procurement costs and services and staff that government not willing to pay. It requires diplomacy and high-level diplomacy at the highest level. And we have talked about the backsliding of rights for key population, but we need to take this also as a public health, public health, right, that we need to address the needs of key population, and we need to raise awareness at the highest level, at country level. Good high-level engagement, but with all sectors, not only those that we traditionally work with, like the Ministry of Health, Ministry of Finance, but at the same time, sometimes human rights is commission, oversight bodies, and this require coordination and building trust and accountability, because each actors as the their own part to contribute to this. Social contracting takes time, and it needs to be a phased and strategic process. We've seen in these countries by experience that in the past 2 funding cycle, like at least 6 years to move some needles and some key activities to be implemented. And also in most of these countries, some of them have a different level of preparation, but we are yet to, having outcome-based contracting. We need also to adapt the responses to the country context, legal and policy, because in some places, countries, they don't want to call social contracting. They have other ways of calling social contracting. They want to also adapt to what is existing with other ministries outside of, the Ministry of Health. And some of them, it's easier to engage the decentralized government bodies, like municipalities, where you can find other ways of paying for these services at the community level, but at the centralized level. Others would have some hybrid solution where they will provide services within the CSO's premises, but would not channel funding to the CSOs. So this requires changes in financing framework, building the capacity of the government to do the social contracting, and also all the health governance structure. Sometimes they need to adapt or for the piloting of social contracting. How can we engage the community? I think we need to enable the environment, mainly investing in, I think, through the grants, not giving specific example, but we have facilitated policy dialogue among all actors in the community, and support activities to advocate for the public financing of community-based services. We need to support activities that can optimize the cost of services, as we've mentioned previously. Some current costs of the services at the community level at a level that the government cannot assume. We need to empower the CSOs to deliver the services and standardizing the packages in a way that it can support public health targets, as we have mentioned before, and to mobilize resources. Also, coordinate with all sectors, because we have to share ownership of the outcomes of this discussion. And also, we work with the principal recipients and other grant implementers to work to raise awareness on the needs, and also collaborate towards reaching the goals of social contracting. Strategic planning, we need to plan within the context of Global Fund grant implementation from the country dialogue towards grant design and implementation, but at the same time, we have talked about the importance of having community data. We need to support, in the grant we have supported CSOs to use community level data that we can integrate into the health information system that will inform also the decision, strategic decision at higher level. Sustainability, we need to work with the CSO governance and also strengthening the leadership and financial resilience to work and help them map capacity, but at the same time, strengthening them in a way that they can lead the discussion and sit at the table in country, so they can also influence the decision that will be taken on their behalf within the grant and the activities. We need, I think Annabelle will have a presentation to share all the resources to help us towards the continuum of funding requests from the country dialogue that was started for GC8 and take advantage of all the opportunities that we have to leverage the CSO's leadership so they can really meaningfully participate in the grant design and also implementation. Thank you.
Thank you very much, Dr. Mari Agath. Thank you very much. We'll move now to our community speakers. We will be having two community speakers, one from Morocco and the other from Moldova. We'll start by Morocco from North Africa with Dr. Mohammed Al-Khammas, who is a physician and a public health expert who has been committed for over 20 years to the fight against HIV with a human rights-based approach. He's widely recognized in Morocco and across the MENA region for his community leadership and strategic action from grassroots work to international platforms. He's the head of international programs at LCS. He has led numerous innovative initiatives in HIV testing, psychosocial support for people living with HIV, and harm reduction for people who use drugs. He also serves as president of Coalition MENA-H, which is a prominent regional coalition that brings together several community networks. Dr. Khammas, please go ahead.
Merci Amjad. I am sorry, I'm speaking French. C'est avec un grand honneur que je
It's a great honor for me to share the experience of Morocco for the piloting of social contracting. I would like to thank the organizers for their invitation. As an introduction, I would like to say that some of the point of the framework that some points align with the Morocco context. For example, partnership with CSOs is an example of cooperation in public health. Global Fund play a key role as a second financial supporter for the HIV 30%. TB 5% since 2003. Morocco has received continuous support of Global Fund, more than 150 billion. So though Morocco is not classified among transition countries, Morocco is preparing for transition with its institutional support. The process is coordinated. There's an institutional context that favors it, and there is the So yeah, I wanted to remind him to go slower so that we can interpret. So have other activities, many also in sports sector. If we examine the annual report of 2023 on the collaboration between the government and CSOs, there have been mobilizations of more than 6 million, but for the specific area of HIV sector, the mobilization of resources is more complex because of the specificity of key population targeted by some thematic program, which are also criminalized in some conservative cultural context despite all the different progress. So the challenges continue to be key barriers in targeted mobilization for HIV services. And social contracts are within a general vision of the fight against HIV and tuberculosis, want to focus on leveraging the results and work toward global SDG. So after the withdrawal of some external funding, we would like to have some sort of national support, innovative support for priority action activities, including treatment and also engagement of civil society for program targeting key population and vulnerable populations. So in terms of objective, social contracting focus on mobilizing national resources for sustainability and also the progress toward universal health coverage. So social contracts have been strategic risks in the process engaged by Morocco in the fight against HIV and tuberculosis. So in 2016, there have been risk analysis on the sustainability of intervention. In 2018, we identified concrete action for mitigate transition. In 2019, a budgeted plan was elaborated defining priorities to follow. And between 2020 2024, the effort led to an impact mainly through grants of global fund and also through the integration of social contracts in the 2024-2030 plan. And there have also been a change in national policies and also advocacy at the national level for national resource mobilization, engagement of community organization, and also a development of a community roadmap to prepare them for transition and reinforce the engagement of the different stakeholders to ensure the sustainability of results. To prepare social contracts, Morocco focused on structured services from 2021 to 2024, focusing on creating the technical basis for transition. In 2021, there have been an analysis of opportunities and modalities of contracting with NGOs, and the analysis were done with the support of UNDP and UNA. And then we have also a development of minimum package of services for key population. In 2022, we had a costing study of HIV and TB intervention to really target the financial need. In 2023, social return on investment assessment help also see the added value of community services. And in 2023-2024, Morocco engaged the elaboration of an investment document for the two diseases with the support of UNDP. Those steps were followed by advocacy for the mobilization of national resources and the awareness raising of national actors on social contracts, and also give orientation to anticipate and succeed transition. So the main elements of the analysis in 2021 confirmed that the participation of communities and CSOs is a key pillar and historic pillar for national response to HIV and TB. The study also helped capitalize the experiences of Global Fund for the building of strong public contract with multi-year funding strategy, clear programming, and monitoring evaluation accountability. It recommended the sustaining of the transition plan and mobilize sustainable funding through the Ministry of Health, and also call for the use of existing tool, for example, empowerment, community testing, HIV integration into municipal development with joint Ministry of Health and CRO monitoring. And that would identify as a key condition for the reinforcement of and sustainability of intervention. For the services, in the fight against HIV, Morocco developed a certain number of services to guarantee a targeted response, efficient, and it focused on national protocols and main on standardizing intervention. focusing on the need of vulnerable population, have some services for men having sex with men, have coverage for sex workers, migrant, people living with HIV, children living with HIV, and also TB patients and their contact. So there is a minimum package survey that cover testing, prevention, etc. And it is a structured tool for social contracting. For the 2022 study to evaluate the cost in terms of HIV and TB intervention, focusing on the minimum package of service required in the national protocol, they said that so this result showed that NGOs that are efficient are those that have a high level of activities or that have a specific specialization. So to improve efficiency and optimize resource use, there was a recommendation that CSOs focus on domains of expertise and on performing areas of activities. And this helped rationalize the use of resources and structure social contract for transition. For the evaluation on SRE in 2022 with the support of UNDP, it helped evaluate the social impact of there have been the assessment of some NGOs for their support on people living with HIV, and another organization that was evaluated is OPALS, focusing on reinforcing knowledge, self-esteem, and access to health services. And the result showed that for every dollar invested, the return on investment vary between 5.2 to 7.8. For OPALS, it was 3.2 to 4.9 per dollar invested. So there have been like a strategy for the use of SRE, and this will help for some sustainability. The study also called for the extension of to other domains like and update data in link with SRE every year and have a periodic revision of these SRE results. For the elaboration of investment case for HIV and TB in 2023, the focus was to quantify the return of investment in short and long term. And the process started with an estimation of the economic burden, and we analyzed the costs for societies and economy. After that, we have analysis of and also estimation of health impact in terms of reducing incidence and preventing death, and all these elements help define the economic value on investment on HIV and reinforce advocacy for the mobilization of national resources during the transition process for a sustainable autonomy. So there have been a lot of positive preliminary results that show significant impact. But what we can highlight is that in short term, like 5 years, there will be a reduction of hospital burden and immediate healthcare cost saving estimated at $20 million US per year. In long term, in 10 years, the economic gain could be almost 100 million with proactive and productive workforce. And in terms of health impact, several lives will be saved, and this will also contribute to the attainment of sustainable development goal. So we can say that Morocco has progress in terms of operationalizing social contracts. They work on integrated guide of HIV into local development, and also work on different region. And now there is a charter that is elaborated on TB. There are many projects that are already implemented by different NGOs and local authorities. There is there have been a selection of priority sites for social contract and also a focus on institutional reform. Next year, there will be other effort to sustain contract that exist in some region and also adapt social contract with private sectors. This is in perspective, and also the valuing of community expertise through the integration of community services in universal health coverage via CNS, which is managing space for elements that will support the transition. First is the sustainability of HIV and TB, and this require some support mechanism and review of legal framework of CSO, anything in link with status, financing, fiscality. There are a lot of reform to be revised. There is a need to create a joint Ministry of Health and CSOs that will help pilot social contract or experiment, or either the one in experimentation or those that will come with national strategic plan. It is recommended to train CSOs on the principle of social contract, strengthen the governance and transparency of CSOs for the use of public funds, and also adapt a model for socioeconomic that will help CSOs ensure efficiency of their services. Oh, he's so fast. Allez-y. Yeah, so asking him to go slow so we can follow. Development of synergy between CSOs that will help rationalize available resources, and finally update unit costs to recalculate every 3 years the major changes that we believe are necessary for an adapted resource management and sustainable resource management.
Thank you.
Thank
you
you.
very much, Dr. Khamas. Now we'll move forward to have Christina's session. She will be sharing Moldova's experience on the piloting of social contracting. Christina Chalen is a seasoned project management and public health professional with over 15 years of experience leading tuberculosis programs across Moldova and the Eastern Europe and Central Asia region. She has expertise on coordination and management of civil society and affected communities, meaningful engagement in the TB and HIV response. She had played a pivotal role in strengthening the TB civil society movement regionally, contributing to the emergence and institutionalization of community-led networks and initiatives with the correspondent advocacy for sustainable funding mechanisms. Christina, the floor is yours.
Thank you, Amjad. I will keep short, having in mind that we are quite over the time, but saying good morning, good afternoon to everyone. I'm pleased to present today Moldova's experience with contracting NGOs from domestic funding, which is a multi-partner and multi-year effort that never stopped and are continuously improving. The experience of Moldova starts back in, I would say, with the experience of NGOs in HIV field, which started to be contracted by the Global Fund yet in the round one in early 2000s. This opened the door for civil society to be recognized as service providers. In TB, the process of contracting NGOs from the Global Fund grant started in 2011 only. Speaking about the domestic financing from resources, which in Moldova is the National Health Insurance Company, that involved actually a lot of partners, including Ministry of Health, Ministry of Family and Social Protection, at that time the National TB and HIV response programs, and of course civil society and communities. And that started, the work probably started in early 2010, and in 2015 we had the standardization of services in HIV prevention services, coming with the costing in 2017. In 2017, the first grant from National Health Insurance funds has been allocated to the HIV, to the NGOs working in HIV. Since then, also the NGOs in TB field, with the support with the TB regional grant funded by the Global Fund, started to advocate for TB services also to be included among the priorities in the National Medical Insurance Company Prevention Fund. In 2020, the company launched the first call for proposals for TB services, screening services, and the National Association of TB Survivors, SMIT, became the first NGO to sign a contract for TB services, and received at that time only 4,500 euro. But since then, the amount of allocated funds increased and the number of providers contracted as well, having like 3-4 NGOs per year contracted by National Health Insurance Fund. And the latest committed amount for 2025 is from 55,000 to more than 100,000 euro this year. And while we have a lower and a higher ceiling, because the NGOs are paid based on performance. So it depends also, providing screening services. They are paid first for covered population with screening services, but also to have the results-based indicator. It is also based on number of people diagnosed with TB among those screened. What made the real difference here was the support of the National TB program. So from the beginning, the NTP was not just a counterpart, but a real partner who helped civil society to shape service package, adjust activities, and also advocate for integration into national systems. Without this close partnership, the inclusion of the CSO provided services as priority actions in the national TB programs, community initiatives would not have been possible. So you probably see that the chronological order of activities and measures we undertook. Of course, we have a standardized package of and standardized operational procedures that are regulating the provision of services which are aligned to the WHO recommended standardized package for non-medical community-based services. This is costified and actually the approach for contracting NGOs from domestic funding, it is aligned with contracting NGOs from the Global Fund funding, which is still continuing in Moldova. But every year it is divided. The districts, there are districts covered by from Global Fund grant, and there are districts covered from the National Health Insurance Funds, but the approach is the same, the costs are the same. And it is continuous work. Even now, by tomorrow, the civil society organizations should provide their feedback to the National Health Insurance Fund on the costification of screening costs for TB for the next year. So the government and all the stakeholders involved in this process are trying to align and also be up to date to meet the needs of beneficiaries, but also to have a fair remuneration for the NGOs. Speaking about actions, we also still have challenges. Although we are providing the services, or the NGOs providing the services are guided by the standards for screening, for adherence, and so on. This package is not yet officially approved at the level of the Ministry of Health. How the work of the NGOs is regulated, it is through annual orders of the Ministry of Health to include these activities and to regulate them. That's a partial recognition which allows services to continue, but advocacy for formal endorsement remains a priority for the civil society organizations. The coverage is limited by the financial and human resources. Even if the contracts are signed, sometimes the services remain uneven across the country. The most high burden districts are selected for involvement of NGOs in provision of services, and actually they are focusing mostly on key vulnerable populations for TB, and partnering with local authorities as well. The sustainable funding and fair tariffs. So in the beginning, probably the tariffs were not meeting the needs or reflected the real costs that NGOs were supporting. The mechanism of contracting was not the one so accessible and so easy to implement for the NGOs, being applied the same contracting mechanism as for public health institutions. but communities responded by generating evidence, costifying, justifying the costs, and engaging permanently in the discussion with the Ministry of Health and National Health Insurance. And so the adjustments are accepted. What I mentioned earlier, that currently we are undergoing a similar process just now. To summarize, the domestic financing of civil society is achievable, but that's a step-by-step process which requires persistence, technical evidence, and continuous relationship building. What lessons we can share with other countries? The most important is to to work hand in hand always with the governmental structures, and in the case of CSOs working in TB or in HIV, that these are the national programs. Having the national programs as an ally is essential to move and prioritize when advocating for domestic contracting. Analyze country mechanisms for domestic funding of non-governmental sector. When the CSOs start to think about sustainability and how it can be ensured, they should do an assessment of already existing mechanism in country, being that granting by the ministry.
Maybe we can wrap it up.
Yes, Niluka, yeah. Being it granting by the ministries, by the local authorities, contracting for services from national health insurance funds, other mechanisms. So the country should see what are the possibilities and which are the most feasible for them. Build strong relationship with the Ministry of Health and other decision makers for contracting. Develop a common and endorse a standardized package for the services they intend to provide. This, first of all, gives to the NGOs a unified platform, as well to the governments a clear structure for what they are paying for, and adapt similar practices from other contexts. See what has been done in the region. Moldova did not have this chance to learn too much because was one of the pioneering countries, but now there are a lot of examples how domestic financing can take place. So those should be analyzed and also adapted to the local context and strengthen internal capacity. What we saw in Moldova, not the regulations or the model of contracting has been adapted to the possibilities of NGOs, but NGOs have improved their capacities and aligned to the national requirements to be able to implement government-funded programs. So it should be started small in pilots, demonstrate results and bring evidence, and then expand, and as well looking for diverse funding, revised funding mechanism, advocate for revising funding mechanism, define costs for all services. So the domestic financing can transform community involvement from short-term projects into sustainable integration within the health system. I'll stop here. Thank you so much.
Thank you, Christina, for your presentation and for your sharing of Moldova's experience. We'll move now to Annabelle Metzner, technical advisor of the Community Engagement and Community Rights and Gender Department. She will be sharing with us the resources and tools to support community engagement and transition and sustainability, what exists and what is needed.
Thank you so much, Amjad. I will be very quick, given that I know you have already shared a lot of time during this webinar. We just wanted to update you very briefly about an existing toolbox that we have developed at the Global Fund that compiles a range of resources developed by community partners for community partners. It includes resources around community engagement in global fund processes, including funding request development, grant making, but also implementation. It includes resources to support community engagement in CCMs. And you find it on the Global Fund website, and I'll post the link in the chat in a second. The toolbox currently also includes a number of tools on sustainability and transition. For instance, a community guide to the Global Fund Sustainability Transition and Co-Financing Policy, which is really a brief overview of this policy. And a second document around intensifying civil society engagement in Global Fund transition and sustainability processes, particularly in the Latin America region. These tools around sustainability and transition are a little bit older, so we're currently thinking about updating them, and we're also thinking about developing any other tools that could really support communities engage in sustainability and transition planning at the country level. So this is why we would like to hear from you, which type of resources or tools would be helpful for you. Any community guides? If so, in which topic? And which of the topics you've heard about today would you like to learn more about? You can put your response in the chat. Please just add it there by the end of the webinar today. And alternatively, you can send a brief message to us via ceta@theglobalfund.org. We will look at your input and then included when developing and updating the tools that will help community engagement, especially also during grant cycle 8. And we're planning to update the full toolbox early next year, around January, February, so that all of these tools will then also be available on the Global Fund website. With that, I'm handing over to Amjad.
Thank you very much, Annabelle, and sorry for the short presentation, but we're a little bit short on time. I would like to thank everyone from the speakers and the participants for being here today for this webinar. Again, I will focus on what Annabelle just said. If you have any type of tools or resources that you think would be helpful, or topics that you would like to learn more about, please, if you want to add them in the chat right now, or you can send them to the CETA team. And thank you again very much, and see you hopefully, everyone, and thanks again. Goodbye.
Bye.